to ensure that whatever you people require, that is covered. So my idea is just to make sure that you people learn what you are supposed to go for. So today's topic is child psychiatry, mental state examination and assessment. And most of the time, people find it difficult to comprehend how to handle a child, how to do the mental state, because the children are usually not responding to all of the questions in general adult mental state examination. So you have to go a little bit with the different techniques to do that. And I obviously, when I'm interviewing children, I always use different techniques. Sometimes they are acceptable, sometimes not, because it, again, just like adults, children are also having different kind of disorders where we have to be careful and then move according to what our perception is, carefully moving forward with the interviewing the child. So whenever we are trying to do the children mental state examination, there are a few things which are prerequisite to that, and then we move forward. एक कता जब्त खोने की अजियत को कहाँ समझोगे, छुप के रोने की अजियत को कहाँ समझोगे, घर के दालान सदा वुसतें आबाद के तुम एक कोने की अजियत को कहाँ समझोगे, सैकड़ों लोग मुयस्सर हैं रफाकत के लिए, तुम ना होने की अजियत को कहाँ समझोगे. Mental state examination in children. And I want to go forward with this presentation in a way that we want to make sure that you understand what is the prevalence and emergence of the most common pediatric psychiatric morbidity and disorders by age, and then identify individuals with the risk factors that should lead to formal mental health and screening, and outline a structured approach for pediatric psychiatric history taking and mental state examination. For this, there are two things which are used here in Canada, the HEADS framework and the colder mnemonic and motivational interviewing strategies, which we will talk about the HEADS, HEADSS framework, and colder, COLDER mnemonic, what they are and how they are applied as HEADS and colder, and describe key components of mental status examination and how it can be useful in general history taking to clarify the diagnosis. Ultimate aim is to make sure that a firm diagnosis is established to proceed further with the management of children with various psychiatric morbidities. Whenever the child psychiatric specialities are opted, which is usually after your 4 years of psychiatric training, same as here in the West as well. If you want to do specialization in child psychiatry, first 4 years, 5 years of residency, 4 years and sometimes 5 years of residency is in general adult, and then you opt for second fellowship in child psychiatry, which usually is for 2 years. And I think it's the same in Pakistan as well, the 4 years of psychiatric general adult training, and then 2 years of subspecialization in child psychiatry. Although I haven't heard if somebody has passed the child psychiatry FCPS in Pakistan yet, but people are joining child psychiatry as subspecialty to move further with it, which is a good thing, because we need child psychiatrists, because there is extreme shortage of child psychiatrists in Pakistan. So child psychiatry itself has multiple subspecialties like general adult, and it can be academic, forensic child psychiatry, research, psychoanalysis, system of care, and infant psychology. So there is a psychiatry which is called a neonatology in psychiatry, or again infant psychiatry. And there in West, in US, there are psychiatrists who have specialized in infant psychiatry, like Dr. Zishan from US is working as an infant psychiatrist, and he is coming to Pakistan regularly, and of course doing various presentations at various fora to make you people understand what is child psychiatry and infant psychiatry. Why we need forensic child psychiatrist? Again, because of similar situations. So if child has committed a crime, they are usually not punished just like the adults. They are usually sent in juvenile centers. And then here in the West, they are punished according to that. Not it's just incarcerated in, again, the jails or, again, detention centers. They are specialized units where children with legal offenses are cared. So we have to move forward with that too. Of course, in Pakistan, we are much behind that. We are not yet at that state where we will be going for subspeciality in child psychiatry, but this is just for the knowledge sake that these subspecialties do exist. Whenever we are trying to assess the children, these are some of the most common problems which we have to assess in children. The most common problems are neurodevelopmental disorder like ADHD, autism, uh, learning disorders, communication disorders, and developmental delays like intellectual disability, some kind of a genetic abnormality, syndromes, Down syndrome, and other stuff. So they are all come under the heading of neurodevelopmental disorders. Then the second kind of disorders are the mood disorders like depressive and bipolar, which usually are common in children. Then anxiety disorders, separation anxiety, panic disorders, phobias, social anxiety, OCD, and PTSD. Psychiatric disorders, otherwise like psychotic disorders, like otherwise like schizophrenia, catatonia, and brief psychotic disorders are usually not very common in children, but we do see some children affected with it. So the prevalence of psychotic disorder is relatively less. Prevalence of anxiety disorders and neurodevelopmental disorder is more, and mood disorder is there as well. Then there are a few other problems which are again common, like feeding and eating disorders. So, anorexia nervosa, bulimia, other eating disorders like pica is common in children. And disruptive impulse control, again, conduct disorders like oppositional defiance disorder, conduct disorder, trichotillomania, they are common. The most problematic area is the substance abuse. These days, unfortunately, number of children in the schools, especially the elite schools, who are in children who have money in their pockets, they are unfortunately involved or indulged or are into it for the drugs, mostly psychedelics amphetamines and other drugs, not usually the stuff that was available previously, like opioids. And alcohol is again not accessible in Pakistan commonly, but crystal meth and Ritalin and other drugs are definitely available, and people can be addicted to these. So substance use disorders are common as well. So the common psychiatric disorders in children, topmost neurodevelopmental, then anxiety disorders, mood disorders, substance use disorders, eating and feeding disorders, again, impulse control and conduct disorders, and lastly, psychotic disorders, some of them. These are the common ones which mostly are used. Specific methods that are used to assess the children are play techniques, projectile techniques, and direct questioning. The direct questioning is usually considered not to be the first option. Play techniques are considered to be the top, and then projectile techniques are number two. And if nothing is coming up, then we may end up and compromise on direct questioning. Now, what I do in my clinic is that I have kept few things with me, which I try to give to a child, uh, like I keep eclairs, which are partly a toffee and partly a chocolate, which is usually very attractive to child. So most of the children, they come to my clinic just for the reason because I offer them eclairs, two at a time, not more than that, and in the presence of a parent, so that they are careful if they are allergic to something or they are suffering from any physical morbidities where they should not be taking that, then the parents know and they understand, and then we can try that. So we have to be careful that whatever we are offering to the child, it has to be under a lot of supervision. So what I do is that I try to offer them two eclairs in my hand, and some children are very much into it and they just grab it. Some children feel that okay, fine, I look at their parents, should I take it or not? And some children are absolutely not interested in that. If the portion of the children who are not interested in the eclairs, then we have to opt for a few other things to break the ice, to start the interview, to start the communication. Something needs to be done. And usually then there are toys or something which is colorful and playful, preferably not harmful to the child. Anything which can be swallowed or can make their hands dirty, they should be avoided. So you have to be careful. So these three techniques, play techniques, projectile techniques, and direct questioning, are the key techniques. Then specific methods like play techniques. What is a play technique? So imaginative play with the puppets, small figures. Play materials are given based on the child's concern, perception, and characteristics, modes of regulating affects and impulses. So choosing appropriate toys for appropriate age and then playing with them in an appropriate manner is the key. So as a child psychiatrist, then people are trained in that, so they know which age needs what kind of toys, and these toys can be used for this age, and then you have to play to make sure that you start evaluating the child. They are used for diagnostic and trust building and form of play as an important information of mental state examination as well. So play technique is basically the key technique and it helps a lot. So most of the places where children are assessed, they are not like general adult clinics with walls and again furniture. They are usually flat with a colorful carpet, some toys in the cupboards, various things that you can take out and use them, whatever the age and other associated situation is. Specific methods like projective techniques, DAP, invite the child to draw a picture. As the child, what animal he or she would most or least like, whom he or she would take along to a desert island or a holiday, what he or she would wish if given three magical wishes. Describe a dream, book, movie, TV show which she recalls or he recalls, and future ambitions. I usually again use these techniques as well, and they are very helpful. So I ask the child if he is not again willing to take the candies, he's not willing to play with anything that I offer her, because I'm not a child psychiatrist, so I don't have a very specialized interview room for children. But of course, in a general setting, whatever is possible, we try to do that. So we usually give pen and paper to a child, which is there always, or pencil, but make sure that the pencil should not be sharp and they should be very safe. They would not be able to swallow or chew it, so we have to be careful. And if the child is at the age of, say, 4 years, 5 years, 6 years, then they are able to respond to other, again, question as well, like animals, what do you like, have you watched a movie? I always go for the movies because this is the most common thing these days in real clinical settings. Most of the children, they watch YouTube. Most of the children, they watch other, again, TV channels. and they know what characters are in today. Like when we were, my children were younger, so I watched Lion King. I still remember 76 times I watched it. And this is Lion King. I watched it for 76 times, but I was not the only one who watched the Lion King with the children. There were other people at home as well who watched the same movie, and I'm sure that they have watched it for multiple times as well. So my kids were so much liking the Lion King that they used to watch it again and again. Similarly, these days there are other characters. So there were Barney, there are other characters. Whatever character you feel these days is in for the children who are watching it, then you should be able to watch it once or twice so that you are familiar with those characters. And when you start talking about those, then the child definitely usually starts talking as well. And you can gather information related to it. So these are the projective techniques. So the first technique that I mentioned, play technique. The second technique I mentioned was a specific methods. And the third technique is again evaluation in the direct form of questioning, which again, most of the time is with the parents, but it can be school teachers, care providers, daycare centers, or whosoever is involved in taking care of a child. So the development process, the cognitive and academic development, the family relationships, peer relationships, development consciousness and value system, interest, hobbies, and talents, unusual circumstances in the house and the family, prior psychiatric treatment or any assessment done, family history or a medical or psychiatric illnesses. These are again very important component. This will give us the idea about the emotional maturity, physical health and well-being, social competence, and communication skills and general knowledge as well. So you are able to assess the developmental disorders, intellectual disabilities, psychotic disorders, major depressive disorders, PTSD, all of those things through these techniques as well. But again, it's variable, it is dependent on how the interview proceeds further, and then you can assess and build up on it. Need to observe and assess in terms of activity level. I hope you people are able to understand this, right? If you have any questions, please stop me. So need to observe and assess in terms of activity level. So some children are actually very hyper kind of children. So they are not having ADHD, but they are active babies who want to engage, who want to participate, who want to talk. And some children, they gradually, again, change their perspective. So they are more, again, living by themselves, isolated, not talking too much. But again, this never means that they are abnormal or they are having any psychiatric morbidity. It's kind of a thing, whatever way they are raised up. So there are children who are very much having high value system. So they talk about very carefully, how are you? They will say, I'm okay, I'm fine. Some children who have religious backgrounds, they may say Alhamdulillah. So it varies, and you have to understand those cultural dynamics as well, religious dynamics as well, before you start talking to these children. Uh, Inactivity period, rhythmicity, how much the child is able to do the things time and again, approachable or withdrawal, adaptability, threshold of responsiveness, intensity of reaction. So he will suddenly shout or scream or yell, and then it will be problematic for you. So you have to gauge the intensity of the reactions, quality of mood, distractibility, attention care, and persistence. That is important. So some children may come up to you, and then when you are starting the interview, they are fine, and suddenly they start fidgeting with the things around in the room, and you are just looking at them that they won't break anything or touch a switch or electrical wires because they are unpredictable. So considering those things, it has to be a safe environment not a general adult clinic room, which unfortunately is the situation. In most of the cases, we don't have appropriate child evaluation consultation rooms at many places in Pakistan. So that is important as well. एक छोटा सा शेर है, हमारी याद के जुगनू संभाल के रखिए, कहीं तो रात पड़ेगी जनाब रस्ते में. So these things hopefully would be able to help you in future as well. Assessments. Pediatric psychiatric assessment should include multiple informants such as patients, parents, teachers, and differential diagnosis is extensive. It is important to keep in mind the age of the child and the likelihood of certain disorders occurring that age. So, like autism, you won't be able to see before the age of 3. Usually, sometimes there is fluctuation. ADHD usually presents in children who are about to go to the school around the age of 5 and 6, and then gradually the chances of developing ADHD at the age of 10 are usually not there. But of course, they are there, but not to the extent at the peak ages. And the true psychotic disorders like schizophrenia and the bipolar disorders are relatively less common in children. I'm saying relatively less common, but they are there. So you may be able to see a child who is having bipolar disorders, but they are less. So the common problems that uh, are coming to you as a psychiatrist will be intellectual disabled, again, neurodevelopmental disorders, ADHD, autism, and sometimes mood disorders. These are the common ones, but of course, there are other disorders as well. Screening process is always, again, we have to be very careful about it. So communal risk and exposure, such as poverty. Now, people say that the poverty won't be able to give much of the psychiatric morbidity, but that's wrong. That's a concept about general people. But we as psychiatrists know that poverty, violence, lack of safe school and environment, or lack of access to healthcare facilities is a major problem in developing a psychiatric morbidity, and especially in children, because again, the understanding is not, oh, common sentence, oh, zara chal aaj hai, or they will say that ऐसा ही लोग है, ओ यार बस इस बच्चे से तो बच के रहो, ये बहुत ही हाइपर बच्चा है, मतलब they will say that, but they won't do anything about it because again, they don't know where to go and whom to seek, and these things are important. You will see children playing on the roads. They are absolutely fearless of the vehicles or things happening around them, which is unfortunately leading to lots and lots of psychiatric morbidity. Again, we don't understand this, but it is there. It's happening so much in our society, in our culture, in our country, unfortunately, that we sometimes are so much, again, used to it that we never pay attention to it. Like children begging on the streets, every crossing that you come across, there are people who are begging, and most of them are children. Unfortunately, government tries to control it, but it's so much that the poverty can lead to so much of the violence as well that things are getting more complicated. Group or individual risk exposure, such as the maternal depression, bereavement, trauma, or catastrophic events. So every now and then there is a catastrophic event. Um, Load shedding, like if the child is not able to sleep at night appropriately because of the so much heat, how he will be able to perform in the school the next day? It's very difficult for the adults as well, who are able to tolerate more. Imagine how much the children would be able to tolerate. Of course, they won't be able to. And then ultimately, if they are able to tolerate it, then they will develop some psychiatric morbidity. And you won't be able to understand that this is a psychiatric morbidity, which is creating problems, unfortunately. Individual characteristics include, but are not limited to, subsyndromal symptoms, functional impairments, behavioral issues or biological predisposition is still a big challenge and a problem. And again, we feel that unfortunately these things are problem common. I don't know who's asking me to make them join. No, I cannot do that. Sorry, they are sending it, but I cannot add them from here. How I can add them here, I don't know. Anybody knows, please go ahead with it. You can add this gentleman, whosoever he is or she is, they are trying to join. I don't know why there is a problem. Okay, continuing forward. Screening and assessment. So the first task usually is whenever there is a communal risk, poverty, violence, lack of safe and schools or healthcare system, what I have talked about, which is again a very, very common problem generally. Even here, when I'm assessing people around the age of, say, I don't see children here, but if I'm assessing people around the age of 17, 18, who are at the cusp of being adult and the children, these things do matter a lot. And the family crisis, the family situations, the violence in the family, poverty, jobs, and all those things that the children are doing when they are becoming an adult, if they are involved in it, they are having definite psychiatric morbidity, which can lead to multiple significant problems in times to come. So, individual or a group at exposure, maternal depression is the most common one. And there was a study, there are multiple studies published by one of the very famous psychiatrists in Pakistan, Dr. Atif Rahman. He is professor of psychiatry in Liverpool, I believe, in UK, but he has lots of research which was conducted in Pakistan about the maternal depression. And there are lots of studies. You must go through that, because if some of the examiners know him in our examination system, they will definitely keep some of his studies, which are very breakthrough studies. And they have significantly proven the fact that depressed mothers give rise to babies who are less in birth weight and having multiple possibilities of developing a psychiatric morbidity. Bereavement, maltreatment, trauma, and catastrophic reaction. Maltreatment, this is again not considered a significant thing, but this is significant. So if I can say that I have again slapped my son, nobody bothers in Pakistan ever. But if I say that once I slapped my son, here everybody will be after you, which will be a complicated situation. So it is not acceptable at all. And again, it depends from culture to culture, system to system, advantage, disadvantage, etc. But this is common, and this is very common in Pakistan. So the child abuse, ek thapad lata, chaped lati, yeah, chanda maar diti, various kind of words that we use. These are common in Pakistan, but unfortunately, these are not acceptable because they lead to complications in child mental health in times to come. Individual characteristics. Now, there are some symptoms which are not qualifying for the psychiatric diagnosis, but they are there. So, if child is very weepy, हर वक्त रोता रहता है, that is not fulfilling the criteria of MDD because there are no other symptoms. But again, if हर वक्त रोता रहता है, चिड़चिड़ा रहता है, परेशान रहता है, then there is something wrong with him, and we have to assess that. And maybe he's not fulfilling the criteria of an adult MDD, but in children, these things are important and significant. फंक्शनल इम्पेयरमेंट, हर दूसरे दिन स्कूल से छुट्टी कर ली, घर बैठे रहे, टीवी देखते रहे. Social media is very common, unfortunately. So all the people have access to the Facebook, Instagram, Snapchat, and so many other groups, social media. Now there is a thread as well. Now there are other things as well. So there are minor differences in them. and people start watching it. And you know what? I have seen children who are watching those videos on these groups, jokes, action things, some adult issues, because there is no restriction there and everybody can access everything. So the children who are about 10 years of age, and if they are in Instagram because they put their ages wrong and they become a member, there is no check, nobody is trying to assess them, then it's a problem for them because they are looking at the adult material. And this adult material, most of the time, is coming from countries other than your own country. And they have cultural differences. So kissing is common in probably some areas, but it's not common in Pakistan. It's never seen in public in Pakistan. And if child starts seeing those things or anything like that, I'm just giving you an example. There are so many other examples. There will be definitely some conflicts in his mind. And if these conflicts are there, you won't be able to assess them otherwise, unless or until, because they won't be suffering from any significant psychiatric morbidity, but the behavior problems will be there. And unless or until you know the root cause, then it's a problem. I always quoted it long time ago. Maybe 20 years ago, I told them I was doing a child psychiatry lecture and tell that we as a parent are responsible for children's behavior. So if you say like घर में बेल बजी है और किसी ने बेल दी है और आप बच्चे को कहते हैं जा यार जाके कह दे अब्बा घर पे नहीं, तो what is the message that you are conveying it to a child? To tell a lie is okay and fine because I'm lying. I'm sitting home. The child can see that. He won't question that you are sitting here and you are telling to the person coming outside the home that I'm not home. So this means lying is appropriate. So these insensible learnings which are happening around us have lots of impacts on child's behaviors in times to come. Seeing violence and again movies, people start believing that this is real and they start doing that. You know that modeling is a common learning procedure in the children. And if they are learning to see the aggression, then things are complicated. So assessment includes the DSM-5 criteria and diagnosable symptoms, which is unfortunately in child psychiatry more complex, more complicated, and difficult job. So we have to prioritize establishing a good rapport, comfort and openness during the discussion. It is important to show interest, offer positive feedback, use open questions, as well as checking on your and their understanding. So you have to keep asking them uh, if they were able to understand what you are asking. So there are times like I'm doing the, again, developmental disability. Even if I have to ask hallucination from a person, it is always in so many simple words so that they are able to understand and respond back. Motivational interviewing such as OARS strategy is useful approach for engagement and assessment. So we will try to cover OARS and then we will wrap up this discussion for today. Hopefully we will try to cover the rest of the 17, 18 slides next time. What is OARS? OARS. OARS. O stands up for open-ended question. Always ask an open-ended question. So it's a two-way discussion rather than direct question. क्या हाल है आपका? Of course, he will say ठीक है. So, but you have to ask open-ended question and try to be as open as possible. Now, every question can be converted to an open-ended question if you are putting a little bit of efforts, and we will talk about it. A refers to affirmative statements. These statements show that you recognize the patient's strengths, success, and efforts to change. It promotes collaborative relationship. Affirmative statements, not मैं समझ सकता हूं. Affirmative statements are good. Well done. Excellent. Wow. These are the affirmative kind of words and expressions, and similarly, these kind of statements as well. Oh, okay, I understand that you have done well. बहुत अच्छा, जबरदस्त, क्या बात है, बहुत अच्छा काम किया, ये आप ये करते हैं, ये तो बहुत अच्छी बात है. These kind of sentences help children to actually open up more, because then they get enthusiastic that the doctor is able to understand me more than anybody else. And you have to give that impression. Your idea is not to gauge or build up a relationship, personal relationship, but a therapeutic relationship where you are able to get the information that you need to make and establish a diagnosis on the basis of ICD-11 or DSM-5, whatever you want to use. Reflective listening, again, is the key in child. Reflective listening is a skill that you listen actively and respond with thoughtful paraphrasing. It ensures that the patient is heard and his statement is validated. अच्छा, फिर आप उसके पास चले गए और आपने उससे ये बात कही. ओके, फिर so reflective listening, you are repeating their sentences. Unfortunately, we don't practice this, but we have to practice this because these are the key components in our interview. And S stands for the summary statements. Recap regularly. Every 5 minutes, recap. And the patient's points and identify the goals to act. So आपने कहा आपको गुस्सा आता था, आप चिड़चिड़े थे, आप घर में झगड़ा करते थे, आपने बहन से लड़ाई कर ली. So these are the summary statements that you have to keep giving in between the interview so that they know that you are listening. So O, open-ended question, A, effective statements, R, reflective listening, and S, summary statements. OARS. OARS is the key word that is essential for to move forward. थक गया हूं तेरी नौकरी से ऐ जिंदगी, आ बैठ किसी शाम मेरा हिसाब कर दे. Well, that was it for today, and hopefully we will try to cover the rest of the things next time. Any questions so far? Anybody? You can write in the chat box. I can see there is a red light on the chat box, but I don't, unfortunately. Okay, let me stop sharing and then, oh, where is it? Okay, I could not move the cursor. Okay. Oh, come on, really? Okay, got it. So now I can move the cursor and see the chat box. Okay, so there was somebody who wanted to join. So if you could please recap OARS. Okay, OARS, I can say it again. O stands for open-ended question. A, effective statements. R, reflective listening. And S, summary. Open-ended question is with multiple answers. ठीक है, आज घर में क्या पका है? Multiple answers are possible. Dal, sabzi, roti, chawal, ya, kaddu, anything. That is O, open-ended question. So any question should be converted into an open-ended question. Affirmative statements. You have to make sure that you keep giving some boost during the interview to the person that you are interviewing so that they understand that I am being heard. Reflective listening. You revise these statements and you give them responses. Okay, fine. I think that you are right. Okay, that you have done an excellent job. I think you were doing much better than what you were doing in the other class. So you were promoted to the new class. Wow, that's good. That's excellent. Now you are a big person. These are the kinds of the words that you have to tell them. And then S stands for the summary. So every 5 to 7 minutes, then you start telling them that, okay, fine, these are the things that we have discussed. It occurs in the adult mental state examination as well. But in children, with the soft, nice tone, especially women have soft, nice tone, so they can talk about these things more. Yes, any other? You can briefly explain play technique again with a practical example. Okay, going back to the play technique. Okay, where was that? Play technique. Usually, if you have toys, uh, okay, Winnie the Pooh, if you have that beer with you and you start telling them, okay, fine, we have Winnie the Pooh going into the jungle now, and he would like to go to the toilet for a special purpose. Where do you think he will go? Where is the toilet? How you use the toilet? How can you pee in the toilet? What do you have to do before doing it? What do you have to do after doing it? Okay, do you think that after coming out from the washroom, before you come out, do you have to wash your hands? So these are the things that you can build around and build up, right? So this is the imaginative playing or the play materials with the characters in it, and it helps. Again, अगर वो आपके डायग्नोसिस की तरफ नहीं भी जा रही बात, तो कोई बात नहीं. अगर 5-7 मिनट आप इस चीज पे लगा देंगे, तो एटलीस्ट ट्रस्ट बिल्डिंग हो जाएगी, कुछ रैपो बन जाएगी, बच्चा आपसे खुश रहो के दोबारा आने के लिए तैयार होगा, और आप किसी एक खास मोड में चल सकेंगे. So that is very important, and you have to ascertain that, right? So this is how you do the play technique and usually move forward with it, right? What else? That's it. Okay. We will definitely try to revise this again next Friday, and we will try to cover this up further slides. Proper mental state examination. This was just the background, and the proper mental state examination in the children as well. Thank you very much for listening to me. Any question, you can just leave a feedback here on the academic group. You liked it, you don't like it, any specific topic you want to move forward with, I'll be happy to do that. Thank you very much for listening. Allah Hafiz.